I am Dr. Atul Kulshrestha, diabetologist and physician at Agra. Friends, today I am going to discuss about the management of type 2 diabetes in present scenario. We know that the management of type 2 diabetes was very simple before 1990 when we were having only two types of drugs, sulfonylureas and the pygonides. But today we are having more than 12 molecules for the development for the treatment of type 2 diabetes. So now the approach is more science plus art combination. As far as the target of management is concerned, we must take care for fasting blood glucose, postprandial blood glucose, HbA1c. Beside this, we have to take care of about the glycemic variability and durability of the treatment, and we have to take care for the reduction on the high incidence of hypo, and the weight gain is to be avoided. So for this, lots of guidelines are there. The guideline approach, every country is having different guidelines, but for last few years the approach to the patient is not guidelines oriented, but it is a patient centric approach. Here we look for the presence of comorbid diseases present in that particular patient, and then we select the drugs and we treat the patient. For example, today I am discussing a case that is a 58-year-old patient with history of type 2 diabetes for last 4 years. This patient is having HbA1c of 8.3, means high. It should be less than 7. eGFR 70 means he is having grade 1 renal involvement. Patient is having normal LDL, HDL, TGs are almost normal, liver profile is mildly deranged. The patient is obese, BMI is 32. Patient is having hypertension, well controlled on the drugs. He is having dyslipidemia, well controlled on the drugs. Presently, he is on metformin, 1000 twice a day, lisinopril for hypertension, 40 mg daily, metoprolol for blood pressure, atorvastatin 40 mg daily, and aspirin. Now, as far as the management is concerned, there are certain problems with this patient. Patient 58 years of age, diabetes duration 4 years. He is obese, hypertensive, dyslipidemic. He is also having obstructive sleep apnea with high BMI. The problem in this patient is to control the blood glucose. That is, we have to reduce HbA1c by more than 1.5%. We have to take care of dyslipidemia. We have to take care of the weight, and we have to take care of to avoid the incidence of hypoglycemia. So for this patient, we have to select the drugs according to the need of the patient and according to the guidelines. Different guidelines, especially Indian as well as international guidelines, says that for type 2 diabetic patient, the first treatment should be metformin. So this patient is already receiving 1000 mg twice a day metformin. So it means metformin is to be continued. Still with metformin, the patient is not controlled. We are having options of different drugs. But if you want to give which is the better drugs for this patient, now let us see. Sulfonylureas, commonly used in Indian patient, economical, but the problem is of weight gain. This patient is having obese, having obstructive sleep apnea because of the obesity. Here we will like to give the drug that is going to reduce the weight, and for that only two drugs are important, that is GLP-1 and SGLT2 inhibitors. As far as the GLP-1 is concerned, it is injectable and very costly. As far as the SGLT2 inhibitors are concerned, they are orally available and they are relatively economical as compared to GLP-1. So the first drug after metformin in this case should be SGLT2 inhibitor. The another drug is to be added because it is very clear in all the guidelines that if the target is to reduce HbA1c of more than 1%, then at least two drugs are to be added with metformin. So this patient is not controlled on metformin. Target is to reduce HbA1c of more than 1.5%. So SGLT2 inhibitors will not be sufficient in this case. We have to add other drugs. As far as the other drug is concerned, the best and physiological drug is DPP-4 inhibitor. That's why if we add DPP-4 inhibitor, there will be further HbA1c reduction, the blood glucose will be controlled, variability of the glucose will be less, and SGLT2 inhibitors and DPP4 inhibitors, they are having synergistic action also. So in this case, after metformin, we can add SGLT2 inhibitors and DPP4 inhibitors. For SGLT2 inhibitors, the most important and the best SGLT2 inhibitors available to us is empagliflozin. That has proven its efficacy in EMPA-REG trial, in EMPEROR-reduced trial, in empagliflozin in cardiac failure, empagliflozin in renal failure. So everywhere, if you consider SGLT2 inhibitors, empagliflozin scores over other SGLT2 inhibitors. So empagliflozin is preferred SGLT2 inhibitors in this case. As far as the DPP4 inhibitors are concerned, we are having different DPP4 inhibitors, but out of that, linagliptin is considered very, very important because it is cardiac safe, renal safe, and with empagliflozin, it is having synergistic action with decrease in the side effects. So here, SGLT2 inhibitor empagliflozin can be added with DPP4 inhibitors like linagliptin, and then we can achieve the glycemic target in this case very well with a decrease in the body weight of the patient. There is no incidence of hypos when you use this combination, but this patient is having multiple comorbid conditions. This patient is also taking other drugs for blood pressure, for dyslipidemia. So in this case, if we provide fixed drug combination of EMPA and LINA, that will decrease the pill burden. And it is now very clear that if you reduce the pills from 2 to 1, then the compliance will be increased by 30%. So now if we add the fixed dose combination of EMPA and LINA in this case, the compliance will be better, acceptance will be better, pill burden will be better, and the patient can be managed very well. So this was at the end of my talk. So finally, I can summarize this case. In this case, not control on metformin. We are here, we can add SGLT2 inhibitors and DPP4 inhibitor combination available in fixed dose combinations are also available. And by that, one can achieve the glycemic target very well, and one can take care of the comorbid conditions present in this patient. Thank you.